Hey, good morning, everyone, and welcome to Euronurse. I'm your host, Vic Sidis, and welcome to the show. Hey, today's my birthday, so I'm doing this on my birthday. If you want to wish me happy birthday, throw it in the comments. Go ahead. If you're watching this on any of our live channels, that is, put it in the comments. This is your first time visiting us. We do have a website. It's euronurse.com. Check it out where you can find more about the show. Also, best place to go to watch all of our past episodes, and boy, we got a bunch of them. Now, maybe you just want to listen in your car. No problemo. We have an audio version. Just go to our Euronurse Plus area on our website, and you'll find all these different podcasting apps that you can click on and subscribe. And hey, we got a great subject for you today. Thought I'd do something a little different. So this is a contact hour subject. It's syphilis, from the historical tragedies to modern treatment and prevention strategies. So you can get that contact hour. No experts joining us today, just your birthday boy. And I'm going to go ahead and bring us right into our show. And let's let her rip.
Hello, my name is Dr. Laurel A. Robinson, and I'm a nurse practitioner with Norton Infectious Diseases Institute and the Kentucky Infection Prevention Training Center. Today, I'll be presenting a brief PowerPoint on syphilis, titled From Historical Tragedies to Modern Treatment and Prevention Strategies. Funding for this presentation is provided by the Kentucky Department for Public Health. Content includes discussion of unlabeled use of products. The presenter has no financial interests or other relationships with the manufacturers of products, and no commercial support was provided for this educational activity. Our objectives today will be the following: define the 3 stages of syphilis, identify methods of diagnosis and the treatment regimens for syphilis, identify 3 physical manifestations of syphilis, recall 2 strategies for the prevention of contracting syphilis, and to define the implications of the Tuskegee experiment on the African American community. What is syphilis? Well, syphilis is a systemic bacterial sexually transmitted infection. When it's left untreated, it can become very serious and even deadly. Syphilis has been recognized as a disease for centuries, and even now in modern times, it continues to pose a significant public health challenge. The discovery of the bacteria that causes syphilis took place in 1905 by a German zoologist and a German dermatologist. Syphilis is caused by the bacterium Treponema pallidum. They found this spirochete-shaped bacteria in the chancres or sores and inguinal lymph nodes of syphilis patients. Even with this breakthrough, it would still be another 40 plus years before the discovery of the benefits of penicillin for the treatment of syphilis. T. pallidum is an aerobic gram-negative bacterium in a spirochete shape. It is primarily spread through sexual contact, as we just discussed. However, it is also communicable through mucous membrane contact and occasionally transmitted vertically, where viruses can pass between mother and baby in utero. The incubation stage after time of exposure is about 10 to 90 days, with an average incubation period of about 21 days. And in the photo on this slide, you can see an actual microscope image of the aerobic gram-negative bacterium T. pallidum. So when this bacterial infection is left untreated, it causes a serious systemic infection that might lead to serious problems in multiple organ systems, including the central nervous system and the ocular and optic systems. The early neurologic clinical manifestations of syphilitic meningitis are usually present within the first few months or years of the infection. These include cranial nerve dysfunction, meningitis, meningovascular syphilis, stroke, and acute altered mental status. Cerebral spinal fluid exams are warranted with clinical signs of neurosyphilis, and in some cases of ocular syphilis and otosyphilis. Some of the symptoms of ocular syphilis include vision loss, blurry vision, eye pain, eye redness, retinal vasculitis, and optic neuropathy. Otosyphilis can cause tinnitus, vertigo, and sensorineural hearing loss. Syphilis is a nationally notifiable disease with approximately 176,000 cases in the U.S. reported to the CDC in 2021, and approximately 6 million new cases occurring worldwide. A syphilis epidemic is occurring in the United States with sustained increases in primary and secondary syphilis from 5,979 reported cases of syphilis to CDC in 2000, rising all the way to 133,945 reported cases in 2020. That is a 2,140% increase over the last 20 years, despite new technology and treatment methods. Health disparities, unfortunately, are still rampant in this epidemic, particularly among sexual and gender minority populations, and intersections with the HIV and the substance use epidemics as well. Increased morbidity and mortality are attributable to congenital syphilis infections as well. So there are stages of syphilis, and they're classically divided into 3 stages, which include primary, secondary, and tertiary. Each stage has its own set of symptoms and characteristics. Additionally, there is a latent or hidden stage that can occur between the aforementioned stages where there are no visible signs or symptoms, but the infection is still present in the body. Effective treatment will halt advancement to the next stage, so it's very important to educate about how to treat syphilis and, of course, how to prevent contracting it. So the earliest phase of the infection is called primary syphilis. Normally, there is a single painless sore called a chancre. It appears at the site where the bacteria entered the body. The chancre is highly infectious, and it usually heals without treatment in about 9 to 90 days. Now, sometimes there are multiple atypical painful lesions, so you can't just go by this particular hallmark symptom of one painless sore. It can manifest differently occasionally. Chancres are highly infectious. That is the key here. Men will normally see them in the genital area or on the penis. The women typically will see these outside of genitals or inside of the vagina. Typically, there's some lymph node enlargement involved as well, especially in the inguinal area if this is a genital chancre. Despite being painless, the presence of a chancre should prompt immediate medical evaluation due to the high risk of transmission to sexual partners. So it's important to stress this to patients in general, because sometimes when something isn't painful, it doesn't elicit as much concern from patients. However, in this case, they need to not ignore it, even though it's just painless sore that eventually resolves. Now, if there's no treatment, we move on to the second stage of secondary syphilis. It's usually about 2 to 24 weeks after that primary lesion has healed. It's commonly characterized by a mucocutaneous rash appearing on the trunk, the palms, and the soles of the feet. Mucus patches in the mouth or on the genitals or rectum occur in approximately 1/4 of the patients as well. Signs and symptoms of secondary syphilis typically resolve in about 3 months, with a range of 1 to 12 months, but can periodically recur for the first several years of infection in about 25% of untreated persons. So the interval between primary and secondary syphilis the interval between primary to secondary and secondary to tertiary syphilis is known as latency, when no symptoms or signs of syphilis are present. The interval from secondary to tertiary syphilis can actually last for years or decades before symptoms appear. In up to 2/3 of patients, the disease can remain latent for life and never progress to tertiary syphilis. Latent asymptomatic syphilis is divided into 3 categories. Early latent infections thought to have been acquired within the past year. And then there are late latent infections, which are thought to be longer than 1 year in duration, and latent syphilis of unknown duration, where the timing of acquisition cannot be determined based on available clinical, historical, or laboratory data. The treatment regimens do also differ between the latent syphilis stages. So if it's an early latent syphilis infection, benzathine penicillin G and 2.4 million units IM in a single dose would be adequate. However, if it's a late latent syphilis, meaning longer than a year, the dosage would be 7.2 million units total, administered as 3 doses of 2.4 million units IM each at 1-week intervals. So it's important to try to differentiate whether this is a earlier latent infection or a late latent infection if you're treating a person in this stage. We'll talk more about treatment through the presentation. So tertiary syphilis is actually considered rare. It includes cardiovascular syphilis with aneurysms or stenosis resulting from multiplication of treponema spirochetes in the thoracic area or in coronary arteries. Syphilitic gummas with soft granulomatomus growths that can cause tissue destruction in any organ system, including bones and cartilage. And neurosyphilis with late neurologic manifestations. And general psoriasis is also a side effect. Neurosyphilis can occur during any stage of syphilis and can be asymptomatic or symptomatic during any stage of infection. And the recommended regimen for tertiary syphilis with a normal cerebral spinal fluid exam would be benzathine penicillin at 7.2 million units total, administered as 3 doses of 2.4 million units IM each at 1-week intervals. So syphilis screening recommendations per the CDC are displayed here on the screen. And as we can see, the women who are pregnant and at the first prenatal visit and at the beginning of the 3rd trimester, if delivery is a risk, are recommended as for screening for syphilis. Also, any sexually active men who have sex with men should be screened at least annually. Of course, every 3 to 6 months if there's an increased risk. People living with HIV that are sexually active should all be screened annually. More frequently if there's individual risk behaviors where they may be contracting syphilis during that year period between the next test. So these require an in-depth history with your patient, especially if there's any reluctance to be screened and you feel that they are part of the recommended screening group. And basically, any person with any signs or symptoms suggestive of syphilis should be tested for syphilis. You don't have to just go by the recommendations. Anyone with an oral, anal, or vaginal sex partner who has recently been diagnosed with syphilis should be tested for syphilis as well. So the diagnosis of primary syphilis actually involves a combination of a clinical exam, the history, and laboratory testing. The CDC still recommends the dark field microscopy or direct fluorescent antibody DFA tests on chancre exudates to confirm the presence of T. pallidum. Additionally, serologic tests such as the non-treponemal and treponemal tests are used to detect antibodies against the syphilis bacteria and to monitor the response to treatment. So a presumptive diagnosis of syphilis actually requires the use of 2 laboratory serologic tests. non-treponemal tests, such as a VDRL, which is Venereal Disease Research Laboratory, RARPR, which is the Rapid Plasma Regain. Treponemal tests as well needs to be done, and that would be your TPPA assay. Various EIAs are chemoluminescence immunoassays, CIAs, and immunoblots are rapid treponemal assays. So when the serologic tests don't match what you're seeing clinically, the presumptive treatment is still recommended for those who have risk factors or suspected or confirmed exposure to syphilis. And biopsies and other tests can also be considered. All persons who have primary and secondary syphilis should be tested for HIV also at the time of diagnosis and treatment. Those persons whose HIV tests are negative should be offered HIV PrEP. In geographic areas in which HIV prevalence is high, persons who have primary or secondary syphilis should be offered PrEP and retested for HIV in 3 months if the initial HIV test was negative. Syphilis has significant implications for public health, necessitating the reporting of cases to state or local health departments by healthcare providers, laboratories, or both, as dictated by state public health reporting laws. Given that laboratories may not have access to clinical data, it's crucial to report all positive direct detection tests for syphilis, including the specimen site and positive serologic test results, to state and local health departments. State regulations will specify which syphilis test results must be reported and the time limits for reporting laboratory findings. The CDC has issued new recommendations for syphilis diagnosis, including serologic testing and methods for identifying Treponema pallidum. These recommendations are the first comprehensive guidelines from the CDC on laboratory testing for syphilis. Syphilis tests are categorized into non-treponemal and treponemal tests, which detect different types of antibodies related to the infection. Both types of tests should be used together to differentiate between untreated and past infections. Newer serologic tests offer automation, but must be used within a specific algorithm that may include older manual tests. The recommendations are aimed at various professionals involved in syphilis testing, treatment, and disease control, and are subject to updates based on new research or technological advancements. This table from the CDC goes more into detail about specific recommendations for laboratory testing for syphilis. Among these recommendations are the recommendation for endpoint titers to be clearly reported and to not contain mathematical signs, the recommendation for syphilis serologic testing algorithm usage, recommendations for syphilis serologic testing in pregnant women and those with HIV should be interpreted in the same manner regardless of pregnancy or HIV status. And dark field microscopy is recommended, especially in point-of-care testing for primary or secondary syphilis in the concern for timely patient treatment. Primary and secondary syphilis treatment is done per parenteral penicillin G and has been used effectively for achieving clinical resolution. Clinical resolution would be the healing of lesions and the prevention of sexual transmission. However, no comparative trials have been conducted to guide selection of an optimal penicillin regimen. Substantially fewer data are available for non-penicillin regimens. Currently, the recommended regimen for primary and secondary syphilis remains as benzathine penicillin G in 2.4 million units IM in one single dose. Available data demonstrate that the use of additional doses of benzathine penicillin G, amoxicillin, or other antibiotics do not enhance efficacy of this recommended regimen when used to treat primary and secondary syphilis. And just another side note reminder, neurosyphilis and ocular syphilis actually require a different regimen for treatment, as outlined here. So treatment of adults with HIV, again, we're going to use that benzathine penicillin G and 2.4 million units IM in a single dose. Additional doses of benzathine penicillin G or other antibiotics are also not indicated in patients with HIV infections. Patients with HIV and latent syphilis infections should be evaluated clinically and serologically at 6, 12, 18, and 24 months after therapy. And again, we want to interpret those tests the same as people that do not have HIV. So the penicillin allergy always comes up when we're trying to do treatment. And in this case, penicillin really is the preferred method to treat syphilis. In non-pregnant people, there are limited data on alternatives to penicillin, but the pregnant women are the ones that we should really focus on trying to desensitize and still treat with penicillin G, even if they express a penicillin allergy. This can be done with skin testing for penicillin allergy or oral graded penicillin dose challenges. The non-pregnant persons do have the options of the doxycycline or tetracycline. But again, there's limited data on these alternatives. Thorough clinical and serologic follow-up of any persons receiving an alternative therapy is essential because, again, the hallmark gold standard would be penicillin. Yarish-Herxheimer reaction. It's an acute febrile reaction, frequently accompanied by headache, myalgia, and fever, and it can occur within 24 hours after the initiation of any syphilis therapy. It is a reaction to treatment, not an allergic reaction to penicillin. Patients should be informed about this possible adverse reaction and how to manage it if it occurs. The Yarish-Herxheimer reaction occurs most frequently among people who have early syphilis. This is presumably because the bacterial loads are higher during these earlier stages of syphilis. Antipyretics can be used to manage symptoms. However, they have not been proven to prevent this reaction. The Yarish-Herxheimer reaction might induce early labor or cause fetal distress in pregnant women. However, this should not prevent or delay therapy of syphilis. So management of sex partners is very, very crucial in order to alleviate the infection. Managing sexual partners for syphilis. Sexual transmission of syphilis is believed to happen only when syphilitic sores are present, which is rare after that first year of infection. If you've had sexual contact with someone diagnosed with primary, secondary, or early latent syphilis, you should be clinically and serologically evaluated. If contact was within 90 days of the diagnosis, you should be treated for early syphilis regardless of a negative test. If contact was over 90 days before the diagnosis, you should be treated if test results are not immediately available and follow-up is uncertain. No treatment is needed with negative test results. Positive results require treatment based on clinical and serologic evaluation. In areas or populations with high syphilis rates, health departments recommend notifying and treating sexual partners of those with syphilis of unknown duration and high serologic test titers, as this may indicate early syphilis. Long-term partners of individuals with latent syphilis should be evaluated and treated based on the findings. The following partners are considered at risk and should be notified of the need for evaluation, and that would be those who have had contact within 3 months plus symptom duration for primary syphilis, within 6 months plus symptom duration for secondary syphilis, and within 1 year for early latent syphilis. Monitoring after treatment. Primary, secondary, or early latent syphilis. A non-treponemal, such as the RPR or VDRL test, should be performed at 6 and 12 months after treatment. If the initial non-treponemal test titer does not decline fourfold by the 12-month follow-up, or if the titer does not become non-reactive by 24 months, the patient should be reevaluated for treatment failure or reinfection. With late syphilis, including latent syphilis, patients with late syphilis should undergo follow-up serologic testing at 6, 12, and 24 months, as some patients may not have an adequate response for up to 2 years following treatment. Serologic response after treatment. Non-treponemal antibody titers should decrease at least fourfold during the first 12 months after syphilis treatment, particularly among persons treated during the early stages of infection, and might become non-reactive over time, especially among patients treated for the secondary stage of syphilis. However, in certain persons, the decrease in non-treponemal antibody titers is less than fourfold despite recommended treatment. In this case, non-treponemal testing titers along with clinical history of syphilis, physical exam, and sexual risk assessment, including contact history, must be used to determine the infection status. This is a nice algorithm on the initial evaluation of positive serology in the non-pregnant adult. Now, congenital syphilis, we'll touch on here briefly. That occurs when an infection in a pregnant person passes to the baby while in the womb. It can be via blood or contact with lesions on the mother during birth. This is a significant public health problem. The risk factors include poor access to prenatal care, inadequate or no treatment of pregnant mothers who have syphilis, substance abuse, HIV-positive mothers, and clinical manifestations of congenital syphilis include jaundice, nasal discharge, rash, and things as detrimental as skeletal abnormalities and hepatomegaly. The recommended regimen for syphilis among infants and children is benzathine penicillin G, 50,000 units per kilogram of body weight IM. We don't want to exceed that adult dose of 2.4 million units in a single dose for children that are, older, like your adolescent population. And infants and children that are aged over 1 month who receive a syphilis diagnosis should have their birth and maternal medical records reviewed to assess whether they have congenital or acquired syphilis. The prevention of syphilis. Correct and consistent use of latex condoms can reduce the risk of syphilis when the infected area is covered. Many primary lesions go unnoticed in the vagina and rectum. If sexually active, being in a long-term monogamous relationship where the partner has been tested and is known to be uninfected. Partner notification. Many people are not aware until notified by the health department or partner or a provider. And sexual partners of infected persons are very likely to be infected. They should receive preventative treatment per the CDC STD treatment guidelines at the time of the visit without waiting on any diagnostic test results. As we near the end of this presentation, I would like to speak briefly about the Tuskegee study of the untreated syphilis in the Negro male. The Tuskegee study of the untreated syphilis in the Negro male, also known as the Tuskegee syphilis study, was a clinical study conducted by the U.S. Public Health Service between 1932 and 1972. The purpose of the study was to observe the natural progression of untreated syphilis in rural African American men. Circulating brochures were used to invite people, Black men in particular, to participate in a study that would help rid them of this, quote, bad blood, end quote, which was a loose term for common ailments such as fatigue. Macon, Alabama was chosen due to having the highest incidence of syphilis in the country at the time. The Public Health Service, in collaboration with the historically Black college Tuskegee University, enrolled 600 African American sharecroppers. 399 of these men had been previously diagnosed with syphilis, but 201 of them did not have syphilis. A Black nurse was even used to help gain the trust of the men and get them enrolled into the study. These men were mostly poor sharecroppers and were unaware of the true intentions of the study. Instead, the patients were told they were receiving free health care from the United States government, free treatment for their, quote, bad blood, end quote, and free burial insurance. The participants' informed consent was not collected. As a matter of fact, the men enrolled in the study were never told that they even had syphilis. Instead, researchers kept this information from them and continued to tell the patients they were being treated for bad blood, a local term again used to describe several ailments. The men were so grateful for being taken care of, and they thought they were getting free help. Being a poor sharecropper from Macon County, Alabama, did not grant one the opportunity to see a doctor very often, if at all. The doctors and researchers in charge of the study really wanted to see the effects of untreated syphilis on these men. They wanted to see whether the disease affected whites and Blacks differently, as they felt that this was primarily a disease for Black people. They had no plans of treating these men, even though the men were told they were receiving medical treatment and medicines. The interest was really only in the data that would be collected at these men's autopsies. Participants were left to deteriorate from this tertiary syphilis, which can include symptoms of tumors, heart disease, paralysis, blindness, and insanity. Even when penicillin was discovered to be a cure for syphilis in 1947, no one initiated therapy on the participants or even tried to stop the study. And when clinics were opened to treat people from the area, there was a person sent out there to make sure none of the men from the Tuskegee study slipped through the cracks and were treated with the rest of the public, as that would compromise the study. The story finally broke in the Washington Star on July 25, 1972, in an article by Jean Heller of the Associated Press. Her source was Peter Buxton, who was a former United States Public Health Service venereal disease interviewer and one of the few whistleblowers over the years. The Public Health Service, however, remained unrepentant, claiming the men had been volunteers and were always happy to see the doctors. The New York Times wrote, quote, "For 40 years, the United States Public Health Service has conducted a study in which human beings with syphilis who were induced to serve as guinea pigs have gone without medical treatment for the disease, and a few have died of its late effects, even though an effective therapy was eventually discovered." The public outcry that followed led to the study's termination. The revelation of the study's unethical practices actually sparked national outrage and contributed to the establishment of federal regulations for the protection of human research subjects, including the creation of the Institutional Review Boards, IRBs, to oversee research involving human participants. During this time period, 40 wives of these men were infected with syphilis, and 19 babies were born with congenital syphilis. These historical traumas certainly provide critical context for interpreting present-day occurrences, but attributing distrust primarily to these instances ignores the everyday racism that Black communities continue to face. Reputable research has demonstrated that Black Americans continue to experience disparities in healthcare. Black Americans frequently have their pain denied, are labeled as drug-seeking. Their conditions are misdiagnosed frequently, and necessary treatments are also withheld by physicians. In these moments, those patients are probably not thinking about Tuskegee, but rather contemplating about how an institution sworn to do no harm has failed them. In other words, the African American distrust of the healthcare system is deeply ingrained and justifiable. The unethical Tuskegee experiment is just part of the story. As Harvard historian Evelyn Hammonds told the New York Times, quote, "There has never been any period in American history where the health of Blacks was equal to that of whites. Disparity is built into the system. So we must acknowledge how medical history has institutionalized racism." The CDC has provided a untreated syphilis study at Tuskegee timeline and website directly linked to photographs and the history of the experiment. Please take a look at it at this particular link when you have a moment. Because of the Tuskegee experiment, Congress passed the National Research Act and created a commission to study and write regulations governing studies involving humans. The Office for Human Research Protections was established to oversee clinical trials. Now studies require informed consent, communications of diagnosis, and accurate reporting of test results. We will end with a note about blood bank screening. Rarely, syphilis can be transmitted through blood transfusions. The last reported case was quite a while ago in the US in 1966. This could be in part a decline due to universal testing and screening. Also, the cold storage of blood interferes with the bacteria that's in syphilis. And there are also no more donor to recipient transfusions. Blood donations are required to be tested for antibodies, T-pallidum, and persons that donate blood that is serologically reactive are deferred and notified. The FDA recommendations for screening blood donors for syphilis are available at this link and include assessing donors for the history of syphilis or gonorrhea or treatment for syphilis or gonorrhea in the past 3 months, and to defer for 3 months after the completion of treatment. This concludes my presentation on syphilis. Hope you enjoyed it. Please take a look at our website for more informative information on infection control. Thank you.
All right. I hope you really enjoyed it. I think it was very interesting. And be sure to go to the credit area. Go to our website, euronurse.com. There's a little yellow box. It'll say get your CE, whatever. Click on that. It'll bring you to the CME, my CME website, where if you don't have an account, you can register for one. It's all free. You'll just have to take and answer a few questions. You don't have to watch the video. You can just skip through and go to the next box. And then you can go ahead and answer the questions. And hey, you get your free CE all on my birthday. So we do have another episode coming up next week. I want to let you know a little bit more about that one.
This holiday season, UroNurse dives into the latest advancements in urology equipment this year. From cutting-edge diagnostic technology to state-of-the-art surgical instruments, We'll highlight devices that enhance patient care and streamline clinical workflows. Whether it's groundbreaking bladder scanners, advanced lithotripsy systems, or revolutionary robotics, UroNurse is your guide to what's next in the world of urology. Join us next week for expert insights and practical tips on integrating these game-changing tools into your practice.
So that's always a fun one. My Christmas show is I've been doing for the last 2 seasons, so this will be the 3rd time I'm doing it. Where I get a chance to kind of look through and see what new what new inventions or what new innovations, that's the word I want, what new innovations have come up through the past year, 2024. I'm sure there's always going to be a lot of them, and I like to share those with you, but I don't want to spoil it for you. So join us next week. Hopefully some of our experts will be on for that one, since we will be going to you live. Anyway, join us next week, and we'll see you for more.